not have a quorum at this time, so we're going to start in a subcommittee. Just to make an announcement, we have people out in the hall waiting for a seat as well. So if you're just here to testify on one bill, if you don't mind, if you could maybe, how do I say this nicely, leave if you're, if you could vacate some seats, if you're just here for one bill, that would be helpful to get some of the other people in. So we're going to start with Senate Bill 1089, Senator Nurrenbern. And we'll probably stop you to establish a quorum, and we may even exec if we get a quorum in here. So sorry about that in advance, but whenever you're ready, you can start.
Good afternoon, Madam Chair and members of the committee. For the record, I am State Senator Maggie Nurrenbern, representing the 17th Senatorial District in Clay County, and I'm here to present Senate Bill 1089. Senate Bill 1089 requires health benefit plans that provide maternity benefits to cover a home blood pressure monitoring device for pregnant and postpartum women, along with coverage for the education and training necessary to use the device correctly. The device is a standard at-home blood pressure cuff that allows individuals to regularly check their blood pressure and share those readings with their health care provider. Missouri's Pregnancy-Associated Mortality Review report covering data from 2018 to 2022 ranks cardiovascular diseases as the second highest cause of pregnancy-related deaths, behind mental health conditions, accounting for approximately 25% of pregnancy-related deaths. The home blood pressure monitoring devices are prescribed when a physician or other healthcare professional identifies a patient as being at increased risk for pregnancy-related complications, such as preeclampsia or other hypertensive disorders, or when an underlying condition is present. When used throughout pregnancy and the postpartum period, home blood pressure monitoring allows for early detection of dangerously elevated blood pressures before it leads to a serious complication such as stroke, seizure, organ damage, emergency deliveries, or in severe cases, preterm birth or loss of life. Many families with private insurance do not have reliable access to these life-saving tools. Even when a physician identifies a risk and writes a prescription for a home blood pressure monitor or provides appropriate clinical support, coverage is inconsistent. As of February 1st, 2025, our MoHealthNet covers the cost of a standard home blood pressure monitor and related education and clinical support. This bill focuses on private insurance coverage, and I'm sure they're here to testify in support, closing the remaining gap for families who rely on private plans and ensuring access to this basic low-cost form of monitoring during pregnancy and the critical weeks after birth. This legislation will save mothers' lives and save babies' lives and help ensure more Missouri families can bring their newborns home safely. Thank you for your time and consideration. With that, I'm happy to answer any questions.
Thank you. We're going to establish a quorum real quick. We're going to do that part, and then we'll go to questions. Barb, please call the roll.
Senators Crawford.
Here.
Gregory. Here. Brown. Huff. Here. McCreary. Here. Mosley. Trent.
We do have a quorum. And any questions for the bill sponsor? Senator Gregory.
Absolutely love it. I look forward to helping you too. So appreciate you bringing this forward. That's a serious issue.
Absolutely. Thank you, Senator. Appreciate it.
Senator McCreary.
So this is already available for pregnant women that are on MoHealthNet?
Correct.
Okay, so this would just impact people
who, with a private health plan, and so it's asking if that health plan covers maternity benefits, that this would be something that would be covered as well, right? And so it's one of those things. Unfortunately, I think probably far too many of us know folks who have been impacted by preeclampsia and how serious this condition really is. And again, in terms of how much it costs, it's very cost effective to be able to monitor this at home with in conjunction with their provider to, again, save lives. I mean, there's so many people. I know there's going to be several folks here to testify in support of this legislation. But again, this is one of those really common sense things that can help moms get through their pregnancy and then again postpartum. Thank you.
Further questions? Seeing none, just for my benefit, how many are here to testify in favor of this bill? Okay. How many against? Okay. Just a reminder, we have 1 hour, and so we need to keep our comments succinct, and please don't repeat what anyone else has said. We want to hear from everybody, but we need to roll this along pretty good. So I'll ask for the first one here that's in favor of Senate Bill 1089 to please come forward at this time. Also, don't forget to fill out a witness form, and if you'll keep things rolling if you can, as fast as you can, that would be helpful.
Thanks, Arnie. I appreciate you.
Okay. After I got up, everybody else did. Is there a delay? Okay. Thank you very much, Madam Chairwoman, members of the committee. My name is Arnie C., AC Dienoff, State Public Advocate. You know, this bill 1089, it's common sense, and it should be a bipartisan legislation. Too many times we get crept up, whether I'm a Republican, she's a Democrat, but we need to have common ground and cross those paths to get what's beneficial for our 6.2 million Missourians. Why would an insurance company, a private insurance company, fight and protest Missourians over an in-home blood pressure monitor? This bill, in my opinion, is a no-brainer. It's going to cost the private insurance companies not very much money, but they're going to have a huge return on investment at the end of the line because it's going to be a great prevention issue. This bill should be, in my opinion, a consent bill. These in-home blood monitoring pressure machines will create great data, and it's create prevention of other medical issues. And at the end of the day, like I said, it's going to save private insurance companies a lot of money and a lot of prevention of ongoing medical costs. For those reasons, this bill should have passed a long time ago. I don't know why some things take a decade or more to get passed in this General Assembly in the state capitol, but I'm a big supporter of SB 1089. Thank you, Madam Chairwoman.
Thank you for your testimony. Any questions for this witness? Seeing none, next up in favor of Senate Bill 1089.
Good afternoon, Madam Chair and committee members. My name is Dr. Melissa Tapey. I'm an OBGYN, and I'm the Chief Medical Officer at Affinia Healthcare in St. Louis. We are a community health center. I want to say how important this is, not only as a physician but for my patients, but also at an administrative level. As a chief medical officer, I often handle some of the processes that we have in place in our offices and on labor and delivery. And I can tell you, when we can consistently provide the evidence-based care that we know improves outcomes for moms, for babies in pregnancy and postpartum, that is cost-effective, that is a no-brainer. Right? And remote blood pressure monitoring is one of those devices and one of those processes that we can put into place. I take care of many Missouri Medicaid patients. We do have this in place for them. It has been a wonderful device and process to use for our patients. We would love to be able to be consistent across the board with the same evidence-based care that we know improves lives and outcomes for our families, for our privately insured patients as well. For our Medicaid patients, this also will help such that the inefficiencies, right, and the inconsistencies with denials and with appeals gets better as the process for all of our patients get better. And again, remote blood pressure monitoring is cost effective. A day in the hospital is expensive. A day in the NICU is inexpensive. Readmission postpartum is expensive. This will save lives, this will matter, and it's cost effective. Thank you very much.
Thank you for your testimony. Questions for this witness? Senator McCreary.
So why do you think MoHealthNet covers this? Why do you think?
Well, I would hope here in the state of Missouri that we care about our women and our families, and I do think it's cost effective, right? Okay. MoHealthNet is wanting to provide the best care in the most cost-effective way. This allows me to diagnose preeclampsia and hypertensive disorders early, so I can treat them and I can deliver a healthy baby in the safest way possible, which is generally speaking the most cost-effective way possible as well. It can prevent readmissions. I've seen moms be able to stay home. I've been able to titrate their medications and they can stay home with their baby, bond, breastfeed, whatever it is they choose to do, and that is also a positive outcome for that family.
Very good, thank you.
Further questions? Seeing none, next up, thank you for your testimony. Be sure and fill out a witness form. Next up, in favor.
Madam Chairman, members of the committee, Trent Watson, registered lobbyist here on behalf of the American Heart Association. Just want to lay our support for the bill and happy to answer any questions.
Questions for the witness? Seeing none, thank you for your testimony. Next up, in favor.
Good afternoon, Madam Chair, members of the committee. Chris Ropey here on behalf of Nurture Kansas City, which is a non-for-profit that deals with moms and babies and serves the 6 most challenging zip codes in Kansas City. Cardiovascular disease is the leading cause of maternal mortality for black mothers, which primarily is who we are serving in Kansas City. Most of these are preventable. This would be a great measure and step to help get that under control, because it's unacceptable, the numbers that we're seeing right now occurring in our state. Be happy to answer any questions.
Questions for this witness? Seeing none, thank you for your testimony. Next up, in favor of Senate Bill 1089.
Hello, Madam Chair and members of the committee. My name is Dr. Jessica Norton, and I'm a generalist OBGYN and the Assistant Medical Director of Reproductive Health at Affinia in St. Louis. Since July 2024, we've been working to implement a remote blood pressure monitoring program for our pregnant and our postpartum patients, and we've seen these programs work. Providing patients with home blood pressure cuffs during pregnancy and the postpartum period has improved patient engagement, allowed us to identify hypertensive disorders of pregnancy early and prevent complications that might lead to emergency department visits, hospital readmissions. I cared for a patient who was a 34-year-old with a history of elevated blood pressures outside of pregnancy. At her first prenatal visit, we enrolled her in our program, we got her a home blood pressure cuff, and we were able to titrate her antihypertensive medications at home, outside of her routine office visits. We eliminated the need for her to seek emergency care. She was very compliant. She took her blood pressures daily. She engaged in our care managers who assisted her with taking her blood pressures effectively and educating her on her disease. And then in the 3rd trimester, she developed critically elevated blood pressures, was directed to labor and delivery, and delivered a healthy baby. Our ability to monitor her blood pressure at home allowed us to control her hypertension better throughout her pregnancy compared to her prior pregnancy, which was complicated by a very early delivery and superimposed preeclampsia. Maintaining these programs depends on reliable billing and reimbursement. Many of our patients, as we mentioned, are covered by Medicaid, which does cover the remote blood pressure monitoring program, but we continue to face significant challenges with coverage, reimbursement, especially for our privately insured patients, and even when the home blood pressure monitoring is listed as covered in policy, we find reimbursement to be delayed, denied, requiring repeated administrative follow-up, and creating uncertainty for providers and inequities for our patients. So 2 patients with the same risk factors receiving care at the same clinic but can face very different access because of their insurance is unacceptable. Senate Bill 1089 helps address this inconsistency by establishing clear, uniform, private insurance coverage for both home blood pressure monitoring devices and the related clinical services. And I know we've already spoken to the cost effectiveness. Reimbursement for the device is around $60 to $70, and for the wraparound services around $11 to $15. Whereas costs for readmissions across the U.S. is over $731 million. So I respectfully urge your support of the Senate Bill 1089, and I thank you for your time.
Thank you. Questions for the witness? Next up, in favor? And just a reminder, we've got to go quick because we have session at 1 o'clock and we have 3 more bills. So please, I want everybody to be heard, but just please make it quick. Thank you.
Madam Chair and members of the committee, thank you for the opportunity to testify. My name is Paola Rivera. I'm a fourth-year medical student at the University of Missouri and grew up in Kansas City. Prior to coming to medical school, I spent almost 10 years working for the American Heart Association, including leading initiatives focused on reducing cardiovascular disease among women. That background strongly informs how I approach maternal care today, and it's why I decided to pursue a career in women's health. Cardiovascular disease, including hypertensive disorders of pregnancy, remain one of the leading cause of pregnancy-related deaths, especially in Missouri. According to the CDC, cardiovascular conditions affect a growing share of pregnancies nationwide, with high blood pressure present in approximately 6 to 8% of all pregnancies, and rates are continuing to rise in recent years. Pregnancy often reveals or worsens existing cardiovascular risk, making early and consistent blood pressure monitoring an essential tool for patients identified as higher risk. In clinical practice, blood pressure home monitoring is one of the most effective tools that we have to identify concerning trends early before they escalate to emergencies. Contrasting to the prior clinical story that was shared, I recently cared for a young woman who visited triage for extensive swelling at 32 weeks. She was unaware that her blood pressure had been creeping up, and so she was subject to preterm labor and an early birth, as well as a C-section, which was increased intervention that could have been avoided had she had access to a home blood pressure cuff and was monitoring her blood pressure at home. While progress has been made through HealthNet, as we shared, access for patients with private insurance remains inconsistent. From both a cardiovascular and obstetric perspective, this is a practical preventative policy that will save lives. I respectfully urge you to support this bill, and I appreciate your hearing.
Questions for this witness? Seeing none, thank you. Next up in favor.
All right, Madam Chair and members of the committee, my name is Dr. Haley Baker, and I'm a maternal fetal medicine fellow at Washington University in St. Louis. I care for patients with high-risk pregnancies, including those with hypertensive disorders that require close monitoring. Hypertension in pregnancy does not end at delivery, and in some cases it first develops after birth. The postpartum period is particularly high-risk time when patients may no longer be seen frequently in clinic, but remain vulnerable to serious complications. Home blood pressure monitoring provides a critical safety net for those patients during this transition. For high-risk patients, timely access to a home blood pressure cuff can mean the difference between early outpatient intervention and emergency hospitalization postpartum. However, the effectiveness of these devices depends on patients knowing how and when to use them correctly. With proper education and training, patients learn how to take accurate readings, recognize concerning numbers, and know when to contact their provider. They also understand how to share their readings with their care team so providers can review trends and adjust treatment as needed. This guidance empowers patients to participate in their care and allows clinicians to respond to warning signs before they become life-threatening. While Medicaid coverage has improved, private insurance remains inconsistent. From a clinical standpoint, unfortunately, risk does not change based on insurance coverage. Senate Bill 1089 ensures that patients with private insurance have access not only to home blood pressure cuff monitoring devices, but also to the education and clinical support making monitoring effective during pregnancy and the postpartum period. This bill supports evidence-based care for high-risk patients and helps prevent avoidable complications, keeping pregnancies safer and helping ensure healthier outcomes for mothers and for babies and families. Thank you so much for your time and consideration.
Thank you. Questions for the witness? Seeing none, next up in favor. How many more in favor? Okay, we're going to start timing. You're going to have to keep it quick, or we're going to start timing.
I will not even need a time limit. Chair, members of the committee, Jessica Petrie-Telemaque here for BJC Children's Hospital and the Reach Healthcare Foundation in Kansas City. Just want to go on record in support of another tool to help physicians keep moms and babies healthy.
Thank you. Questions? Seeing none, next up in favor.
Madam Chairwoman and Committee, I am Taylor Lavelle, a medical student at the Springfield Clinical Campus, speaking on behalf of the MFAFP. Currently on my clinical rotations, we recently saw a patient at 3 months postpartum come in with complications from cardiovascular disease. It is important, even in the postpartum period, to be managing blood pressure. She had presented to the emergency room 3 times, and on review of those, her blood pressure was elevated. Had she been monitoring at home, communicating with her OBGYN or family practitioner, we could have prevented her death that ultimately happened
happened due to a heart attack and complications from cardiomyopathy that could have been caught in this period. Cardiovascular disease is a preventable cause of death in the peripartum and pregnancy period, as well as the postpartum period. So we urge you, even up to a year after, to monitor blood pressure.
Thank you. Questions for the witness? Seeing none, next up in favor. Is this it? Anyone else? Okay.
Hello, Senator Crawford. Thanks for having us here today. My name is Misty Todd. I'm a family physician who practices full scope obstetrics in Roll, Missouri. I'm also the program director for family medicine role training program in Sedalia. This not only affects our patients, it affects the entire staffing of a labor and delivery unit in a small hospital. When we have anywhere from 30 to 50 patients expecting to deliver per month, we keep track of their comorbidities, of who we think is going to deliver early, if I need to pull extra nurses to staff in NICU if we're going to have a preterm baby, if we can safely keep moms and babies there together. Increased monitoring means increased expectations, so we can better keep moms and babies together at the time of delivery in our rural hospitals.
Thank you. Questions? Seeing none, next up in favor.
Hello, good afternoon. My name is Natalie Long. I'm testifying on behalf of the Missouri Academy of Family Physicians in support of Senate Bill 1089. I am a family physician. I deliver maternity care and deliver babies. And I think we've established that this is a really simple, cost-effective, evidence-based way to support moms during their pregnancy and postpartum to prevent a lot of complications. We should make getting a blood pressure cuff as simple as ordering a breast pump or a glucometer. These are other things that our patients really benefit from, and being able to monitor at home is a super important part of that.
Thank you. Questions for this witness? Seeing none, next up in favor.
Kara Hoover on behalf of SSM Health, and want to thank the sponsor for bringing the bill forward. Anything we can do to help pregnant women receive better care, we are in support of.
Thank you. Questions? Seeing none, anyone else in favor? Seeing none, anyone else here to testify in opposition? Let me see hands again of how many against. Go ahead and come forward. Okay.
Good afternoon. Hampton Williams with the Missouri Insurance Coalition. Obviously not testifying to the intent of the bill, but do have some concerns. There was a similar bill last year that was filed. I don't believe it was specific to either postpartum or maternal care, but the question came up about specifically the transmission portion of it. I believe I have to go back to my members to figure out which one or how many private insurers are currently providing coverage for this type of material. But last year the discussion was the cost of the what was defined as the wraparound services or the reporting device. Analog cuffs exist, and I've received similar orders to monitor my own blood pressure, and so trying to identify what those cost disparities are between both services. I have found a study which does quantify the cost for continued care. It differs greatly from some numbers that you've heard today. Look forward to working with the sponsor to share some of that information and work on this together.
Thank you. Questions for the witness? Seeing none, next up in opposition to Senate Bill 1089.
Madam Chair, Shannon Cooper today representing America's health insurance plans, and it almost pains me to speak in opposition of the bill, but here I am like usual. Maybe just point out, and there was a lot of confusion about what private insurers do and do not. This legislation, if passed, would affect 28% of the private and commercial market in this state. As you all know, ERISA plans are exempt from anything we do in state law, and years ago when I came over here, we had about a 50-50 mix of ERISA state-regulated plans. Today we're at 28% on the state-regulated plans. While many of our private insurers do provide this coverage, because that's what the employers who purchase these products would like for their employees, there's some that do not. But what always concerns us, and this won't be the first time I'm up here this afternoon to oppose the bill, is as we provide more, as we put more and more mandates on the private market, more employers make that decision to step away from a state-regulated plan into the ERISA products, and as that group gets smaller and smaller, it just puts that burden on the people who probably can least afford those higher rates. So be happy to answer any questions.
Questions for the witness? Seeing none, thank
Thank
you
you,
for
Madam Chair.
testimony. Anyone else in opposition to Senate Bill 1089? Seeing none, anyone for informational purposes only for Senate Bill 1089? Seeing none. Senator, any final comments?
Appreciate the committee's time. Thank you.
This will conclude the hearing on Senate Bill 1089. Next up, we'll hear Senator Washington's Senate Bill 1229. Senator, whenever you're ready.
Good afternoon, Senator Chair Crawford and the rest of the committee. Thank you for having me here today. For the record, I'm Senator Barbara Ann Washington. I represent Kansas City and Jackson County, and I'm here today to present Senate Bill 1229. As you've probably heard several times before, we are facing a maternal health crisis here in Missouri. And it's just gone on too far for us to continue to ignore what we're experiencing. To put it plainly, we're one of the most dangerous states in the nation to have a baby. We rank number 8 in maternal mortality. Our state, the statistics tell a devastating story of the lives lost that could have been saved if we put in the proper measures. Senate Bill 1229 is a common sense solution. Madam Chair,
Yes,
can
ma'am.
you make your senators be nice when they're looking at me?
Are they like giving you dirty looks or?
Yes, ma'am. Thank you.
Shame on them.
You fixed it. Thank you. By requiring insurance coverage for midwives and creating a framework for doula reimbursement, we're attempting to expand the circle of care with this bill for our Missouri mothers. We want to ensure that every woman, regardless of her zip code or income status, has access to specialized continuous support that is proven to improve birth outcomes. So to kind of better understand this, we have a pregnancy-associated mortality review board, and 80% of the pregnancy-related deaths in Missouri for the last couple of years were determined to be preventable. Black women in Missouri are 2.5 to 3 times more likely to die from pregnancy-related causes. The mental health conditions increase, and they also are a leading cause of our pregnancy-related deaths. In our rural communities, 40% of our counties lack a hospital with obstetric services, and we have maternity deserts throughout the entire state where our midwives are often the most accessible providers. We currently rank 29th out of 48 for maternal mortality, which is approximately 25.4 to 32.3 deaths per 1,000 live births. There are third world countries that have better maternal mortality rates than we do. Third world countries that don't even have hospitals, and they use midwives and doulas to improve to have good numbers. So this act will focus on 2 things. One, midwifery coverage, so that health benefit plans will offer coverage to include services for midwives. I live in Kansas City on the state border, and that's something that's been done in Kansas for decades, like a long time. Equal reimbursement, that insurance companies will reimburse the midwives for the services as they would a physician for the same service, especially in those deserts where we don't have obstetric care. And non-discrimination, so any language in an insurance plan that discriminates against midwifery or inhibits in-network reimbursement would be rendered void and unenforceable. The second pillar is doula registration and reimbursement. We currently do have some doula reimbursement with MoHealthNet. So this would direct the Department of Health and Senior Services to create a formal registration process for doulas and allow them to be eligible for health insurance reimbursement as well, making services accessible to more than those who can just pay out of pocket or MoHealthNet. It explicitly states that registration is not a requirement to practice. It's simply a mechanism for insurance participation. Basically, if you want to get reimbursed, you must register with DHSS. Currently, our law does not explicitly require private health plans to cover midwifery. This would close that loophole. It establishes the new registry, and it voids restrictive anti-midwifery clauses in insurance contracts, which would shift the power back to the patient to choose their own provider. We need this bill to close the gap, improve our numbers on maternal mortality. We need it to help our rural communities more than anything, where the hospitals are closing at alarming rates. Midwives could be really helpful. This bill can ensure that they can sustain their practices through fair reimbursement. And we need this bill because research consistently shows that doula and midwifery care leads to lower C-section rates, fewer preterm births, and higher breastfeeding success, all of which reduce long-term health care costs for the state. And with that, I'll take any questions.
Thank you for that. Questions for the bill sponsor? Seeing none, first up in favor of Senate Bill 1229.
Did she have a question? Oh.
I'm sorry, did you have a question?
Did they have a question? Oh, okay. Good morning, Madam Chairwoman, members of the committee. Once again, my name is Arnie C., AC Dino, State Public Advocate. Again, this is a common sense piece of legislation. It should be bipartisan. It's serving Missourians, and it's giving Missourians a clear choice of how mothers want to deliver their babies and how they want to have medical services. In my opinion, why would a private insurance company or Mo Health Net, why would they not want to pay for doula or midwife services? It's so much less expensive. It's a less drain on medical facilities and hospitals. And if you've been to the hospital and seen some of the bills to have a child, the hospitals are going to charge a lot more than a Missouri doula or midwife. So this is clearly a saving measure. It provides choice to Missourians of how they want to deliver their babies and medical care. And so this is, again, a no-brainer piece of legislation. I'm not exactly sure why it keeps coming up year after year and why we can't get this across the finish line in a bipartisan fashion onto the governor's desk. I don't know if it's insurance coalitions or insurance lobbyists that are trying to fight and block this issue, but it's a clear savings to insurance companies. Again, this legislation is a no-brainer. I'm a supporter of SB 1229. Thank you, Madam Chairwoman.
Thank you. Questions for the witness? Seeing none, next up in favor of Senate Bill 1229.
Good afternoon. My name is Tyler Travers, registered lobbyist here today on behalf of Missouri Appleseed. We want to go on record in support of this legislation. The senator laid it out pretty well. This is forward-thinking, proactive. It'll save money, but more importantly, the lives of mothers and children. So I just want to be on record in support.
Thank you. Questions for the witness? Seeing none, next up in favor.
Madam Chair, members of the committee, Chris Ropey here again on behalf of Nurture Kansas City. Statistics show that midwives or doula involvement leads to fewer birth interventions, including expensive C-sections. This will place Missouri on a level playing field of something that has only been available to the affluent and will help again reduce our infant mortality in the state of Missouri.
Thank you. Questions for the witness? Seeing none, next up in favor.
Hello, my name is Ashley Lawson. We're testifying in support of Senate Bill 1229. The Missouri Doula Association and the Doula Foundation are the two clients that I represent. We are in every rural county within the state of Missouri, as well as Springfield, Columbia, St. Louis City, and Kansas City. The average cost for a doula is $1,500. For every dollar spent on the front side, the insurance provider saves $7 to $10 on the back side. We are strongly in support of this bill for that reason. We also would ask the bill sponsor to include the language from the state plan amendment that the Department of Health and Senior Services work with community organizations and resources to establish and maintain the doula registry. And with that, I'll take any questions.
Questions for the witness? Seeing none, thank you for being here. Next up, in support of Senate Bill 1229. Seeing none, anyone here in opposition to Senate Bill 1229?
Lisa Panett here with Armor-Vine. I want to reference certain parts of the bill. A doula by any other name is still a doula. In this case, the first part of the bill, a midwife, references under 376.1755, it references another section, 376.1753, and it gives that definition of a midwife. That one says any person holding current ministerial or I'm going to butcher that word, but certification by organization accredited by a national organization for competency assurance may provide services in 42 USC. And when you go to 42 USC, you see that that is certain doula fellowships that have been able to take place. One in particular in Massachusetts was covered under that 42 USC. Then when you go to 3761758, that is a doula. We're going to cover physical, emotional, and educational support, including the health insurance reimbursement portion. Planned Parenthood now says that we have abortion doulas. It says that we have death doulas. And it says that we have transitioning doulas. So all of these things are going to be covered if we so choose to move forward with this legislation. And for all these reasons, we are opposed.
Questions for the witness? Seeing none, next up in opposition.
Thank you, Madam Chair, members of the committee. My name is Gary Gaddis. I'm speaking on behalf of the Missouri State Medical Association. A bit about me, I happen to be a career emergency physician, not an obstetrician, but I've been a professor of emergency medicine, and as such, I'm highly attuned to the value and importance of proper training for one's role in the health care of patients. I want to thank you, Senator Washington, also because I understand through our lobbyists that you've been receptive to hearing some of our concerns about the bill and moving forward, because what we're raising is concerns about what's currently written. And I'd call your attention to page 2, lines 36 to 41, where the proposed statute is currently written doesn't really seem to differentiate between the different levels of midwives. And we are strongly in favor of certified nurse midwives. Heavens, my daughter-in-law, who lives in Norway, on December 9th last year, delivered a child at a hospital, so if anything bad happened, that they were there, attended only by a midwife because she had a routine delivery. And that went great. But again, not all midwives are created equivalently. If you look at lines 36 to 41, the bill treats them as if they are. And I think, and the state association thinks that for the good of patients and the safety of patients, that scope of practice and scope of training matters. And we don't like the way that the current ruling, the current language fails to stratify based on level of preparation and training. Thank you. I'll be happy to answer questions.
Questions for the witness? Seeing none, thank you for your testimony. Next up in opposition.
Good afternoon, Senator. I'm here to testify in opposition. I did not know that we could ask the senators not to give us dirty looks earlier. I don't think this applies to lobbyists, so. But we have similar concerns with respect to the scope language. From my research, there's been 2 states that currently mandate private insurers cover these services. Rhode Island, which has a prior authorization provision. Louisiana has a cap on the total benefits. Other states, Utah, California, have expanded that to Medicaid. They've not been put on private insurers. Certainly have identified or have seen many of the statistics that were reported. I've been able to identify a report identifying a correlation between fully insured patients and the lack of access to medical facilities for child care. Again, happy to work with the bill sponsor on trying to identify this issue and some ways to address it. Thank you.
Questions of the witness? Seeing none, next up in opposition.
It's been a painful day for me, Madam Chair. Shannon Cooper today representing America's Health Insurance Plans, and just a few concerns we have, and I think they've been stated, but it might interest the committee that I did take a deep dive into doula services 2 years ago with Mama Hakeem and, what's the name of the village?
Uzazi Village.
Uzazi Village, and it was an eye-opening experience, and I do truly believe that there are situations and individuals in this state who a doula would be helpful to. That being said, we are very concerned about issues with education, standardization, and making sure that the doulas are all on the same page and we know exactly how they've been trained. There seems to be some resistance out there and a lot of independence within the organizations, but I know the state's using them to a certain extent, and I think that's gone well. So we would prefer to continue to work with the sponsor and see how the state plan continues to get along with them. With that, I'd be happy to answer any questions.
Questions for this witness? Senator Mosley.
Anyone using a doula, don't they have the opportunity to choose who they're using with and inquire on what kind of training they have? I mean, it's your choice on what doula you use. Is that correct?
Yeah. Currently, there's I'd say kind of a unique market with the doulas, and certain individuals who are having children are very interested in using those services without a doubt. From our perspective, and I guess our concern is always, is there a standardized training when we try and credential these individuals into our plans? Like if we put a new MD in or a OBGYN, it's pretty clear when they fill out their credentialing forms of where they went to school, where their education's at, things like that. And I think that's just maybe from the organizational standpoint with the doulas, maybe they're not that advanced yet. I'm not an expert on how the state registers them to work in the Medicaid program, so I couldn't answer that.
And don't the doulas a lot of times work within the hospitals where there are registered nurses as well there, and
my experience,
OBGYNs?
My experience in the Kansas City was that many of these individuals use that doula for support to help them not only through the birthing process but from the entire pregnancy, just to help them be a support system, a network system for them to go through the entire 9-month process, not just come to the emergency room. But yeah, they are not the sole person at delivery of that child. They are surrounded by a medical team, and I think oftentimes that individual that is using that doula just feels comfortable with that individual. They've chosen someone that they trust and like to be there. But again, from our position, there's not a standardized test or credentialing service out there to where we know they've all got the same level of education. I hope that answers your question.
Okay, so to your knowledge, there's no training?
Pardon me?
You said to your knowledge, there's no training for doulas? Is that
Yeah,
what
no,
you said?
I don't know that you can go to University of Missouri and enroll in a doula course, whereas other physicians that we would credential in our plans have a set educational standard.
Okay, but you did use a doula yourself? You said
I
your
did
wife
not
used
use
one?
a doula.
You said your wife used a doula?
No, she relied on me. It wasn't always easy, and she'd probably tell you that.
I misheard you because I could have sworn I heard you say that you all used to do it. Okay.
Further questions for the witness? Seeing none, thank you.
Thank you, Madam Chair.
Next up in opposition. Seeing none, anyone here for informational purposes only?
Thank you, Madam Chairwoman and members of the committee. Samuel Lee with registered lobbyist at the Campaign Life Missouri to go on record, well, for informational, reluctantly, for informational purposes only, because we would like to be able to testify in favor, but because of circumstances outside of this bill, there's some concern we have, and that is we're waiting for a decision by Judge Jerry Zhang in Jackson County on the old Amendment 3 that was passed in 2024. Part of that lawsuit by Planned Parenthood is to allow non-physicians to do abortions in Missouri. Specifically, they've filed suit against our law, which only allows physicians to perform or induce abortions. We won't know until after April 10th sometime after April 10th, we don't know when, whether our laws are going to be upheld or struck down. If they are struck down, that means that nurses, physician assistants, and potentially midwives could be performing abortions in Missouri. And based on the language in here, in lines 28 through 41, that means that they would be reimbursed like any physician would be for performing or inducing an abortion. There are 19 states where abortions are performed or induced by midwives. We don't want Missouri to be the next one, but it's in the hands of the courts right now. And so I would just ask this committee to be cautious about it. And if this were to move and if it was added as an amendment to a bill, which gets to the governor's desk, and we have this decision by Judge Zhang, which really upends what our law is right now, well, we would have to have a discussion with the governor about what to do with that legislation. So, again, I would love to be able to testify in favor of it, but because of circumstances unrelated to this, just have concerns.
Thank you for your testimony. Questions for the witness? Seeing none. Anyone else for informational purposes only? Seeing none, this will conclude the hearing. Oh, I'm sorry, Senator, did you have any final comments?
Now, thank you for hearing me today, and thank you for having such great control over your committee members. It's so appreciative. Thank you.
Thank you, Senator. Thank you, Senator. This will conclude the hearing on Senate Bill 1229. We're going to go into executive session real quick. I don't know how we're going to get 2 more bills done in the time we have, but we'll see how it goes. I make a motion we go into executive session. Do I have a second? Second. All in favor say aye. Aye. All opposed say no. And the ayes have it. I move that we take up Senate Bill 848. Do I have a second? I have a second. All those in favor say aye. Aye. Those opposed say no. And the ayes have it. This is Senator Justin Brown's bill that we heard last week dealing with the state health benefit plans, and I move that we vote Senate Bill 848 out of committee. Do pass. Do I have a second? Second. Any discussion? Senator Trent?
Thank you, Madam Chair. Just wanted to note that I think we should move this out to full floor for further discussion, but not make any commitment about support at that time. So,
thank you, Senator. Senator McCreary.
I do not support undoing a vote of the people. So, I'm going to vote no on this. I think that there needs to be a discussion about, like, if the people, almost 62% of Missourians voted for this in 2012, and I don't think politicians should just be able to easily undo that. So I think there needs to be some discussion about how we treat the voters' decisions.
Thank you, Senator. Further discussion? Seeing none. Barb, would you please call the roll?
Senators Crawford.
Aye.
Gregory. Brown. Huff.
Present.
McCreary.
No.
Mosley. Trent.
I am going to change my vote to a no.
Madam Chair.
Senator,
change my vote to a no.
By your vote of 4 noes and 1 present, the bill fails to pass. I make a motion that we take up Senate Bill 902. Do I have a second? I have a second. All those in favor say aye. Aye. Those opposed say no. and the ayes have it. This is Senator Henderson's bill relating to the coverage of alternatives to opioids that we heard last week, and I move that we vote Senate Bill 902 out of committee do pass. Do I have a second? I have a second. Any discussion? Senator Trent?
The same as before. I'm happy to help this move out to the floor, but not committing to support there.
Thank you. Barb, please call the roll.
Senators Crawford.
Aye.
Gregory. Brown. Huff. McCreary. Mosley. Trent. 5.
By your vote of 5-0, you have do pass Senate Bill 902. And the last bill we're going to vote on is Senate Bill 932. I make a motion we take up Senate Bill 932. Do I have a second? Second. All those in favor say aye. Aye. Those opposed say no. The ayes have it. This is the bill that I presented last week dealing with the workers' comp percentage changes, and I move that we vote Senate Bill 932 out of committee do pass. Do I have a second? Second. Any discussion? Seeing none, Barb, please call the roll.
Senators Crawford.
Aye.
Gregory. Brown. Huff. McCreary. Mosley. Trent. 5.
By your vote of 5-0, you have do pass Senate Bill 932. I make a motion we move out of executive session. Do I have a second? All in favor say aye. Aye. We're out of executive session. Next bill is Senate Bill 1635. Senator Gregory. Needless to say, session is supposed to start in about 5 or 10 minutes, and we have 2 bills, so fast.
I'll do the absolute best I can. Senator Curtis Gregory, 21st District. Senate Bill 1635 is something that was brought to me last year in terms of discussion and thought processes. We're moving through the Farm Bureau health plan process. What this would do is any health mandate that we pass through the General Assembly would apply to the state-run health plans first to get an idea of the cost effect that it might have on said plans. It sounds like a good enough of an idea that I figure maybe we run into some legislation this year, see what issues or problems there might be, but it's how I would see it working. It applies to the state-run health plans. It would help keep everybody honest when they say, well, if we pass this mandate, it's going to cause everyone's plans to go up by $100 a month. How do you actually know that when it's not been into effect? Unfortunately, I do have to admit the state of Kansas has something very similar. I hate to say I'm copying Kansas, but that is where this came from, and I think we're going to take a look at it.
Questions for the bill sponsor? Seeing none, first up in favor of Senate Bill 1635.
Good afternoon, Madam Chairwoman. Hampton Williams with the Missouri Insurance Coalition. To keep the remarks very brief, currently there is a statutory requirement, 376-1190, that requires there be some analysis of what the cost impacts of mandates would be on programs. It's not really being followed. When we see it in either fiscal analysis, there's not a calculation on how mandates affect premiums or ultimately customers. What this bill would do would provide a more expansive analysis based off actual data from the state, and appreciate your consideration of this issue. Look forward to working with the sponsor and educating the committee further. Thank you.
Questions for this witness? Seeing none, next up in favor of Senate Bill 1635.
Thank you very much, Madam Chairwoman, members of the committee, Arnie C., AC Dinos, State Public Advocate. I think this is a common sense approach to finding cost analysis and seeing where the money falls and how changes and effects affect plans, affect administration, and affect reimbursement costs. For those reasons, I support 1635. Thank you, Madam Chairwoman.
Sorry, questions for the witness? Seeing none, next up in favor? Seeing none, next up in first up in opposition.
Emily Kalmer, American Cancer Society Cancer Action Network. Historically, the Missouri General Assembly has enacted laws to require insurance coverage when there's evidence that coverage is lacking or when patients have experienced access issues. This legislation is going to tell future legislators they have to delay those new health insurance requirements that they want to apply so that they only apply to one state health plan before they can apply to the general state insurance market. This body is well aware of how long it takes to pass some of these insurance requirements, and we don't see a need to further delay the protections for Missourians with this legislation. Under current law, lawmakers can consider each proposed requirement on its own merits. So we have significant concerns this would discourage enactment of new laws that encourage coverage of future innovations in cancer prevention, detection, and treatment, and would ask you to oppose this legislation.
Questions for this witness? Seeing none, next up in opposition.
Madam Chair, members of this committee, Rob Monsess on behalf of the Missouri Hospital Association, registering our opposition. We think, to echo the previous testimony, putting in place a cumbersome system to sort of have to pass these things twice would be pretty difficult.
Questions for the witness? Seeing none, next up in opposition. Seeing none, anyone here for informational purposes only for Senate Bill 1635?
Hello. Sorry, I'm a healthcare consumer today. I am Angela Nelson. I am the director of the Missouri Department of Commerce. Thanks to Senator Gregory for highlighting the rising cost of insurance. I'm here to talk on Senate Bill 1635. I will keep this very brief. As a consumer advocate and as a healthcare consumer myself, I want Missourians to have access to all the care that they want and need. New coverage mandates often address real needs and can positively impact people we all know, but we are facing significant challenges in how Missourians are accessing healthcare coverage, and these cost pressures that we are seeing are driving up premium increases not only in Missouri but nationwide, and that is affecting who can afford coverage. And when people can't afford coverage, they give it up and they lose access to all health care. Outside of the cost issue, I want to focus on something that you all are not aware of, and this is a new issue that has arisen. In the Affordable Care Act, which was passed in 2010, there was a requirement that for states that enacted new coverage mandates after that period of time, that states would bear the cost of those mandates, and I mean pay directly the cost of those mandates. That provision has never been enforced since the law went into effect. We received a draft of a new rule from the Trump administration about 2 weeks ago. And in that rule, the Trump administration indicates it intends to institute that rule, which means that for any mandate enacted by this legislature, the state would actually have to bear the cost of that. If finalized, because that rule right now is in a draft form open for public comment, but if finalized, this rule could create significant ongoing general revenue costs for states, potentially of millions of dollars annually, even for the most modest of benefit mandates. So I want to be clear that, we're not against mandates at all. We're actually very supportive. But when we do fiscal notes for you all today, we're limited to national data, disease prevalence rates, dated costs found in public sources. We rely on what we've seen and heard in other states. This is not ideal, but we wish we had a crystal ball, but we don't. It's the best information available to us. But if we can run a trial through MCHCP for 36 months, our department could get de-identified aggregated claims data from MCHCP. We can analyze the cost and utilization data and report back to you what the actual impact is and what we believe the impact would be on the broader insurance market. With that information, the General Assembly can determine whether to permanently enact a mandate and whether that mandate should continue for the state employee plan. These decisions would be based on current Missouri-specific data. To be clear, Senate Bill 1635 is not anti-mandate, but it is 1,000% about making sure that this body has all the information it needs to make these very important public policy decisions. Thank you, and I'd be happy to answer any questions.
Thank you. Questions for the witness? Seeing none. Anyone else for informational purposes only for Senate Bill 1635? Seeing none. Senator, any final comments?
Let's go on to the next one.
All right. This will conclude the hearing on Senate Bill 1635. And Senator, you may proceed with Senate Bill 915.
Senate Bill 915, again, State Senator Curtis Gregory, 21st District. Up next is Senate Bill 915. is what this legislation deals with. It's actually model legislation, if memory serves correctly, from the conversations from NAIC, National Association of Insurance Commissioners, on how to properly regulate and take a look at the delivery network company market. Since I have filed this, there's been many conversations of which are still ongoing from both sides in the proper way to move forward. And making sure that people that are driving for DoorDash, Spark, which is the Walmart app, and other delivery network companies have the proper insurance coverage when they're out making those deliveries. I can meet with you and talk about how some of that's going to go, or I can do it now, but I think we're in interest of time. What I want to end up with is making sure that the people of the state of Missouri have adequate coverage at all times moving forward. I don't know if the current form the bill is filed then gets us there. I just know it's the model legislation that's put forward, and I know it's been around before, and we're taking a look at it again here today.
Thank you. Questions for the bill sponsor? Seeing none, first up in favor of Senate Bill 915.
Thank you, Senator. And again, Hampton Williams with the Missouri Insurance Coalition. Thank you very much for Senator Gregory for carrying this. We heard this bill last year. The central question that we're still trying to deal with is how do we approach this gap issue? Look forward to working with the senator and stakeholders in resolving that issue. Thank you.
Questions for the witness? Seeing none, next up in favor.
I'm sorry, I'm in opposition.
Next up in favor? Seeing none, anyone here testifying up? Okay, guys, you're going to have to hurry because we're already past 1.
Sorry, I saw somebody else get up. Thank you very much, Madam Chairwoman, members of the committee. My name is Arnie C. A.C. Dinoff, State Public Advocate. I am in favor of this threshold of insurance liability limits. However, I'd like to see the bill amended to something that's more realistic, a threshold that's higher. Delivery networks need to be responsible that those vehicles could hit many vehicles. If they hit 3 Porsches or 3 expensive sports cars, there should be at least a minimum of $150,000 per injury and up to $1 million for a total incident. For those reasons, I support this bill as a starting point. Thank you, Madam Chairwoman.
Questions for the witness? Seeing none, anyone else in favor? Seeing none, anyone here to testify in opposition to Senate Bill 915?
Madam Chair, members of the committee, Jorgen Schlemm on behalf of Walmart. We visited, Senator, I think I've got an appointment maybe later with you, so I'll keep my remarks very brief. I think the key point is when does a person stop using their car for personal use and when does it start becoming commercial use? I think that's the fine line that the Senator is trying to figure out right now. Thanks for all the conversations. We'll continue to work with him. Thank you.
Questions for the witness? Seeing none, next up in opposition.
Good afternoon, Madam Chair, members of the committee. My name is Jeremy Lefevre, appearing today on behalf of my client DoorDash. We want to go on record in opposition. We've sent forward a handful of different compromise options, and we appreciate working with the senator on this. I think what we'd like to see is that the commercial insurance starts as soon as I click that I'm dashing or sparking or whatever the thing is, and then I didn't realize that would get such a laugh, and then extend for some limited period of time after the delivery. Thank you.
Questions for the witness? Seeing none, next up in opposition. Quickly.
Good afternoon. My name is Craig Ortworth. I'm an attorney in St. Louis on the Executive Committee of the Missouri Association of Trial Attorneys. I'm here to testify in opposition to SB 915 in its current form. Not that we're in opposition to its goals. We support those, but how it's currently formatted is what we're trying to work with. I believe we've given you some proposed language, Senator, and we look forward to working with you, again, closing some of the gaps and working some of the issues. Thank you.
Questions for the witness? Seeing none. Anyone else in opposition? Seeing none, anyone here for informational purposes only for Senate Bill 915? Seeing none. Senator, final comments.
I might have to get on DoorDash and get me some lunch. Thank you for the hearing.
Thank you for your patience. This will conclude the Insurance and Banking Committee.